Cataract surgery in an eye with a previous trabeculectomy can affect the long-term survival of the filtering bleb. Hence, the aim of the surgery should be not only to improve the vision but also to ensure good IOP control after the procedure. The biggest risk factor for bleb failure is operating too soon. A minimum gap of 6 months between the trab and subsequent cataract surgery increases the chances of bleb survival. Several glaucomatous conditions are associated with a poor corneal endothelium, and hence a preoperative specular microscopy should be performed. Another preoperative cause for concern is the potential biometry errors in an eye with low intraocular pressure. A softer eye may have with the rule astigmatism, which can resolve when the IOP increases. Also, a softer eye is often a bit shorter, which can lead to a myopic surprise post-op. The biometry of the normal fellow eye and also the earlier refractions of both eyes should be considered while choosing an IOL. These patients should always be counseled regarding the possible need for spectacles post-op. Prior to surgery, discontinue pilocarpine drops if the patient is on chronic miotic therapy. Although usually performed under topical anesthesia, if a peribulbar block is required, no super pinky or weight should be placed over the eye as it can result in shallowing of the anterior chamber or damage to a thin-walled bleb. During surgery, the forceps used for globe fixation should be applied away from the trab site. Avoid handling the conjunctiva near the bleb as small tears can lead to post-op bleb leaks. The corneal incisions should be made 1 to 2 clock hours away from the bleb. A combination of dispersive and cohesive viscoelastics with the soft shell technique can be used to protect the endothelium. A routine phacoemulsification should be performed. If the anterior chamber is showing a tendency to collapse, the infusion bottle height can be increased or the vacuum setting can be lowered accordingly. Iris manipulation should be avoided if possible, as it increases post-op inflammation and is associated with long-term bleb failure. A methodical and thorough aspiration of all cortical material is essential. Complications such as loss of posterior capsular support are also associated with loss of IOP control post-op. Retained cortical matter and viscoelastics have been attributed to bleb failure. And last but not the least, the IOL must be placed in the bag. On the first post-operative day, although both these eyes had a vision of 6 by 6, the stories of their blebs was quite different. The eye with pseudoexfoliation glaucoma had a mild increase in bleb vascularity, which resolved with intensive topical steroid application for 2 weeks, and the IOP was maintained. In contrast, the angle closure glaucoma eye had increased post-op inflammation and a secondary rise in IOP. This required bleb needling and 5FU injections for IOP control. Surgical complications in glaucomatous eyes are not uncommon, and the post-op bleb management is as crucial as the surgery itself. The earliest sign of bleb failure, even before the IOP rises, is an increase in the vascularity around the bleb. At this stage, intensive application of topical corticosteroids can help reduce inflammation and prevent scarring of the bleb. If the bleb vascularity does not reduce, 0.1 ml of 5-fluorouracil can be injected subconjunctivally adjacent to the bleb. If the increased vascularity is associated with an increased IOP, it implies either scarring or encapsulation of the bleb. In this situation, bleb needling with antimetabolite injections can be performed at the slit lamp or in the OR to improve aqueous outflow. Topical corticosteroids must also be continued till the eye is quiet and the IOP under control. To summarize, in an eye with a previous trabeculectomy undergoing cataract surgery, the risk factors associated with loss of IOP include a less than 6-month interval between the trab and cataract surgery, younger age, pre-op high IOP or the use of anti-glaucoma medication, intra-op iris manipulation, posterior capsular rent or vitreous loss, and a post-operative early IOP increase. Hence, these eyes require meticulous pre-op planning, careful intra-op manipulations, and prompt post-op management of bleb failure to ensure sustained IOP control along with visual rehabilitation.